Hi guys, I just come back from visiting my grandparents, and my grandfather told me that he had balanoposthitis. So when he talked about it, he mentioned something important. His diabetes was poorly controlled. That made me wonder there is actually a relationship between glycemic and the severity of this disease.
Yes, I found an article by Sharma titled Glycemic Gravity, the pull of glycated hemoglobin and balanoposthitis severity. The study suggests that in diabetic patients, the higher the glycated hemoglobin, the more severe balanoposthitis may become. I'm gonna share with you this article right after.
What's interesting is that they actually studied diabetic patients with balanoposthitis and found that those with poor glycemic control and had more edema, pruritus, pain, and ulceration.
They also reported a positive correlation between glycated hemoglobin and clinical severity. So, glycated hemoglobin was not only a metabolic marker, but also a possible indirect indicator of how severe the condition was.
But to discuss is probable. It is not enough to just repeat what Sharma says. We need to see which articles support it, which one strengthen it, and which place limit on it.
Yeah, one strength of the main article is that it asks a very useful clinical question. In practice, if you see a diabetic patient with balanoposthitis, it makes sense to ask whether poor glycemic control is making the condition worse.
Yeah, and some articles do support that idea. For example, Lee validates a structural clinical severity scale, which strengthens Sharma's study because it makes the assessment less subjective.
Also, Shan in the Chinese consensus supports a more standardized assessment of balanoposthitis, so even though Li and Chan don't directly prove the relations with HbA1c, they do support the way Sharma showed severity.
So from a methodological point of view, those articles are in favor of the main study.
Other articles support it from a pathophysiological perspective. Bayan explains how chronic hyperglycemia and advanced glycation end products lead to disease damage, persistent inflammation, and impaired health.
That is important because it gives the main article a biological explanation. If this is exposed to hyperglycemia for a long time, it makes sense that it becomes more vulnerable to inflammation and infection.
Along the same line, Takayanagi and the reviews on immunometabolic dysfunction show that poorly controlled diabetes impairs immunity and worsen tissues repair.
And Talanco also supports Sharma because it shows that ureagenesis candidiasis becomes more important in diabetic patients, partly because hyperglycemia increases both house hospital and fungal virulency.
So overall, the main article is supported by studies that strengthen its methodology, its biological plausibility, and its clinical relevance.
There is also support from guidelines. Edwards recognized diabetes mellitus as one of the main predisposing factors of balanitis on the balanoposthitis, especially in the recurrence of severe cases.
And even the ADA 2024 indirectly supports this view by emphasizing that good glycemic control is essential to prevent infections and inflammatory complications.
Still, the main article is not perfect. One major limitation is its cross-sectional design. It shows association, but it does not prove causality.
Exactly, Sharma's study suggests that higher HbA1c is related to graded severity, but it cannot prove that high HbA1c directly causes the worst clinical picture.
So the sample was also small, only 50 patients, and we were selected from a single center, which limits how much the results can be generalized.
And the study did not fully control for the other factors that can influence severity, such as allergical hygiene, obesity, foreskin condition, contaminated infections, or treatment differences. So glycated hemoglobin may be important, but is probably not the whole explanation.
So the methodological criticism is clear. The hypothesis is valuable, but the design is not strong enough to support definitive conclusions. The best example of an article that qualifies the main one is Pihayakumar from 2025.
Yes, because it describes cases of normalcy. Candidal balanoposthitis in patients using SGLT2 inhibitors. In other words, patients with normal or near normal HbA1c who still develop severe genital infections because it treating use glucose.
That doesn't completely contradict Sharma, but it does show that glycated hemoglobin does not explain every case.
So this article acts as important limitation. It suggests that the model proposed by Sharma is useful, but glycated hemoglobin should not be interpreted as the only determining factor.
And that is where Verdosa and the studies about hereditary risk with SGLT2 inhibitors also become relevant, because they show that pharmacological factors and the local environment may also play a major role. So when we look at all the evidence together, most of the articles are in favor of the main article, although not in an absolute way.
Exactly, some support it through methodology, others through pathophysiology, others through clinical evidence, and others through guidelines.
But some articles also show that the relationship between glycated hemoglobin and severe balanoposthitis is not absolute, because the disease is multifactorial.
So rather than saying that some articles are totally in favor and others are totally against, it is more accurate to say that most support the main idea, while some qualify it and limits others.
Yeah, and that makes this discussion stronger because we are not treating this article as absolutely true, but as one study within a broader body of evidence.
So, in conclusion, the article by Sharma provides an important clinical idea. The higher glycated hemoglobin may be associated with greater severity of balanoposthitis in diabetic patients.
Its strengths are that it addresses a relevant question, gives an objective measurement of HbA1c, and supports its argument with a structured clinical evaluation.
Its weaknesses are so clear: cross-sectional design, small sample size, possible sectional bias, and limited control of confounding variables.
Most reviewed articles supported argument, especially from pathophysiological and clinical practice. But some recent studies show that glycated hemoglobin does not always predict the full severity, especially in patients using SGLT2 inhibitors.
Therefore, the most balanced position is to say that the main article is well-funded and largely support, but it should still be interpreted with cautions. Science balanoposthitis in diabetic patients depends on multiple factors and not only at HbA1c values.